and I will also be there. So the participants, I think Ashok, you will introduce me.
Neeraj will introduce.
I welcome Dr. Viti Ingalalikar, Dr. Satyan Mehta, Dr. Neeraj, and Dr. Dhiren Ganjawala to this session.
Thank you, sir.
As you all know, this is all basically to give a venue for young budding surgeons, orthopedic surgeons who are less than 5 years post MS, and to enhance and train them for presentations and probably have our own future faculty ready, second, third generation. And I think BOS wants to promote these youngsters. I'm sure we'll have a great session today also. So over to Dr. Neeraj.
Thank you very much. We welcome all of you, today's speakers and the rising stars of the Bombay Orthopedic Society. Welcome. This is the spine session, as Dr. Sanjay Dhar has already introduced. So I would like to introduce today's star speakers who are the rising stars of BOS. Dr. Sushant Srivastava is going to talk on lumbar spondylolisthesis. Dr. Maitreya Patil is going to talk on adjacent segment disease. Dr. Priyambada Kumar, she is going to talk on spinal tuberculosis. Dr. Ashish Naik is going to talk on vertebroplasty and kyphoplasty. And Dr. Kushal Gohil, who is going to talk on laminectomy versus laminoplasty. With this, I hand over back to Dr. Ashok Shyam to start the session. All the best.
Thank you, Dhar sir and Neeraj, and I welcome all our judges again. To the contestants, the rules are simple. You have an 8-minute presentation and 2 minutes question answer session. I'll be timing the presentations and I'll announce the time that you took at the end of your presentation so that judges know how much time you take. So let's begin with our first contestant, Dr. Sushant Srivastava. Sushant, you can start sharing your screen. Sorry? Yeah.
So is my screen visible?
Yes, your screen is visible. Go ahead, Sushant.
Okay. A very good evening to everyone. I am Dr. Sushant Srivastava. My topic for today is surgical treatment of lumbar spondylolisthesis, current approaches and outcomes. But before we start with this, let us talk or see the burning debates related to lumbar spondylolisthesis. The addition of fusion to decompression, non-inflammatory fusion, versus minimally invasive surgery, interbody versus no interbody fusion, and which interbody approach to use. As these are the burning issues, let us follow an outline or guideline for this. So we will go through the history, the introduction, the methodology to search the literature, pearls of the literature review, take-home message, and the references. So if you look at history, spondylolisthesis comes from the Greek term spondylo, which means spine, and olisthesis, which means slip. Right from 1741, from the age of Nicholas André to 1855 Roberts, people have tried to give their own meaning and definition of spondylolisthesis. The one which we commonly use these days are ventral or anterior displacement of one vertebra relative to the subjacent vertebra. The classifications are many, but the ones of use are one given by Wilsey, that is type 1 dysplastic, type 2 ischemic, degenerative, traumatic, and pathologic. The ones given by Marchetti and Bortolozzi, developmental and acquired classification. Merding's grading of severity of slip in spondylolisthesis is graded as normal, grade 1, 2, 3, 4, and 5, depending on the slip of the vertebra over the adjacent vertebra. This is a schematic diagram showing how the measurements for the Merding classification are made. This example shows grade 2 slip that is between 26 to 50%. Spinopelvic alignment knowledge is very important to treat the case of lumbar spondylolisthesis. This is a heavy slide, but what I would like to drive home the point is pelvic incidence, which is very important, is defined as the angle which is subtended by a line which is drawn from the center of the femoral head to the midpoint of the sacral end plate and a line perpendicular to the central of the sacral end plate. So sacral slope and the pelvic tilt together give the sum of the pelvic incidence. The final classification, that is the spinal deformity study group classification, which actually classifies L5S1 spondylolisthesis to low grade and high grade. The one which we need to understand here is type 6 is important and which needs surgical management. The methodology, data mining, was done using Google, Google Scholar, PubMed Advanced Search Builder, and Cochrane Library. There are a plethora of literature available on the net, but we used the basic thing called as the PubMed Advanced Boolean Operator and Mesh Findings, wherein I got 68 results. I used a normal use of words, that is lumbar spondylolisthesis, surgical treatment, the two modalities of open surgery and minimal invasive surgery. Open surgery consisted of decompression, direct repair, interbody fusion versus MIS, and the outcomes of each. Now, I have tried to place my talk depending on the debates. Now, the first is laminectomy plus fusion versus laminectomy alone for lumbar spondylolisthesis. This is a famous paper by Ghogawala in the year 2016. This was a controlled trial of total 66 patients with spondylolisthesis from 3 to 14 mm. The fusion group had greater increase in the SF36 physical component summary. The cumulative rate of reoperation was less in the fusion group. The scores in the fusion group remained greater at 4 years interval. The ODI scores at 2 years after surgery did not differ significantly. Then comes comparison of instrumented versus non-instrumented fusion in the treatment of lumbar spondylolisthesis. No significant pain change was seen, neither was there any significant difference in satisfactory level for patients. But the higher fusion rate was the one thing which drove home the point of instrumented fusion. Minimal invasive surgery vis-a-vis open surgery. Now, this was a quality outcome database done by Mumanini in 2019. Significant improvement was found in terms of all functional outcomes undergoing MIS with low mean intraoperative estimated blood loss and longer operative times, better ODI scores, and better NRS back pain and LP scores. There was no difference at 1 level fusion, but at the 2 level fusion, the MIS fusions were better. The posterolateral fusion vis-a-vis the transforaminal lumbar interbody fusion. This was a study in 2018 consisting of 282 unique English language studies done by Levin. The pooled fusion success rates were less in the posterolumbar fusion group than the TLIF group. The PLIF patients had significantly lower odds of achieving solid arthrodesis. The ODI scores were better at the TLIF time. Operative time was significantly shorter in the PLF group. There was no significant difference observed in leg pain. The meta-analysis of this study was consistent with the RCTs in favor of TLIF. This study, which is the summary of the treatment of lumbar spondylolisthesis, had a unique grade of recommendation consisting of grade A, B, C, and I, which gave ahead the good evidence, fair, and the conflicting evidence. There were 46 studies, out of which 37 were used. The one which was peculiar here was the algorithm which they used for the surgical management of L5-S1 vertebra needing height restoration or lordosis. If yes, one goes ahead and prefers ALIF. In case of prior abdominal surgery, one goes ahead with TLIF. L4, L5, need of foraminal distraction and revision, lateral lumbar interbody fusion. And the last, need of restoration of L3, L4 with prior, the goes to LTLF. So what are the pearls of wisdom in this plethora of knowledge? Surgical decision is important, individualized for each patient, thinking of the natural progression of the disease, severity and duration of symptom, and the comorbidities. Surgical indications are severe back and leg pain, failed conservative trial, and abnormal neurology. Contraindications are active infection and life-threatening medical conditions. The surgical goal is to address the cause, decompress the foraminal stenosis, remove degenerated disc if any, and correct the dynamic instability. Decompression, absolute indication is abnormal neurology, leg pain, sphincter dysfunction, and claudication. No isolated decompression should be done as it may lead to pseudoarthrosis. Decompression with fusion can be done, but without decompression and fusion, VAS score less than for low backache, translation of more than 1.25, angry facets more than 50 degrees, and disc height more than 6.5. Interbody fusion gives anterior column support, biomechanically superior, build the lordosis and indirect reduction. Posterior fusion, better fusion rate, better clinical outcome, and it is not good for osteoporotic bone. MIS is better with reduced price, shorter surgical duration, and hospital stay. The following are the complications of reoperation: incidental durotomy, nerve root injury, and loosening of screws. So think the natural progression of the disease, severity of symptom, patient comorbidity, surgical skills of the patient. These are my references. Thank you.
Thank you, Sushant. You finished exactly on time. And let's open the forum for judges to ask questions. So I'll invite Ingalalikar sir for questions. Over to you, sir.
Sushant,
Good evening, sir.
how do you compare this with the neglected listhesis? Those ones which have refused surgery and those ones which have progressed. Result point of view, are they all bad?
Sir, if it is neglected, as far as I can answer this to the best of my knowledge, if it is neglected, that means the patient is not having any symptoms. The patient comes to us with a particular symptom or problem, and that is when he comes ahead for some intervention that can either be conservative or surgical.
Okay.
Do all of them worsen over time in terms of symptoms and grade of list?
Yes, sir. Depending on the SDSG classification, that is type 5, in which the plane, the retroverted pelvis has two types, that is the balanced spine and the unbalanced spine. So one which is having the unbalanced spine, patient reaching to this level, having more of leg pain and back pain, having neurological symptoms are the ones which deteriorate.
Okay. So Dr. Satyan, your questions?
Yeah, thanks. Sushant, I'll go back to the beginning of this. Now, you have chosen this topic, right?
No, we have given them, they have chosen the section, the spine section and others. So we have
Okay.
given them the topic.
Okay. I think, the topic is very, very big, very diverse topic. And you have done very well to kind of pick up the points in this. What difficulty did you face in preparing for this topic?
So the biggest difficulty was actually cramming the large amount of 1,853 articles, which I found up till now. And the main problem was actually cramming all this piece of information within an 8-minute talk. So what I really felt was that it would be pertinent and prudent enough to bring in the points which would be problematic for a day-to-day orthopedic surgeon who is just into his clinical practice.
Very good. I mean, I minus points to Dr. Ashok Shyam and plus points to you for doing this. And tell me about you mentioned Gogawala's paper, which is a very good paper. What is the problem with that paper? He has mentioned that all of them, okay, I don't want to give too much out, that basically not too much difference in surgical versus non-surgical. But what is the problem in that paper?
Sir, the problem in that paper is
you remember?
Yes, sir. See, the basic thing which I remember is the ODI scores, which they say there is not much of a difference in the ODI score as compared to the laminectomy plus fusion versus laminectomy. So there is not much of a difference between the ODI scores. That is what I remember.
Okay. I'll tell you one more point. Maybe you missed it, that he has taken all of these listhesis together overall between grade with 3 mm to 14 mm. So it's like a very generalized type of thing where you're not really specifically looking at. Anyways, thank you. Well done.
Thank you, sir. Thank you, sir.
Thanks, Dr. Satyan.
Sushant, can I ask you one question? You've gone through lots of papers. Did you find?
So you are muted, sir. Please unmute.
Say reduction, no reduction. You've gone through lots of papers.
Yes, sir.
And you've seen papers which have on any particular aspect, say for example, reduction, no reduction, this fusion, that fusion. Did you find lots of paper opposing each other on the same aspect?
Yes, Yes, sir. There were a
How-
lot of
how-
contradictory papers
lot
as
of
well.
contradictory papers over any one single aspect. And I'm sure there are multiple aspects to this topic. How did you sort that out?
Okay, sir. So there was one very good paper which actually had a analysis of the past 100-year meta-analysis of the past 100-year publication of lumbar spondylolisthesis. So on the basis of that paper, they had a list of the top 100 papers which had the maximum amount of citation index. And I went through those papers, and depending on those papers, the topics which they actually spoke about, I took them in this talk.
That's great. Dr. Neeraj, your questions?
Yeah,
Good evening,
Sushant,
sir.
your presentation was excellent. I must say that. But I was just going through your slide. I was very impressed with the way you are presenting, and one of the slide just hit me. You mentioned that there is no role of isolated decompression, and no isolated decompression should be done, and otherwise it will lead to pseudoarthrosis.
Yeah. So
But
there is
yeah,
yeah.
let me continue.
Isolated. Yeah, that was one mistake which I uttered, sir. Actually, the line should have been, we can do isolated decompression, but isolated decompression, the complication for isolated decompression may be pseudoarthrosis. That is what I wanted to.
Okay. So even after your correction, this is a wrong statement.
Okay, sir.
Because when we do only decompression, we are not attempting fusion. We are instead preserving the motion. We want the motion to be there. So why you are uttering the word pseudoarthrosis?
Okay.
You're already attempting to preserve the motion.
All right, sir.
Okay.
Okay, sir.
Second thing, even in a stable listhesis, you have not mentioned about that. There is a role of decompression only. I think VTI sir will also agree and add to this.
Yeah, if the listhesis is significant, that means all the structures, both anterior as well as posterior lateral structures, have grown incompetent. And in order to do decompression, if you have destabilized them further, that's not going to work. That probably is not the way to go about. Therefore, according to me, any patient who has come to the stage of needing a surgery for listhesis, probably, unless there's a contraindication for fixation fusion, decompression alone, we have seen not doing too well for too long, maybe a year or two, but they come back with radicular syndromes.
Right. Dhiren sir, you have some comments, questions?
Yeah, just the last question. Are you wiser with your paper or with this study, or you are more confused after?
Sir, I have been this whole exercise of 5-6 days has given me more number of doubts and has actually made me open Rothman. But really, I have learned a lot after doing this data mining, and a few things which I used to think about in the OR has been made clear with the data mining. So yes, it has made me wiser.
Thanks,
yeah, I really appreciate. In 5-6 days, you have really worked very hard. Congratulations for that.
Thank you, sir.
Thanks. So, in view of time, I'll invite the second participant, Dr. Maitreya, to share his screen. And
yes.
Go ahead.
Yes.
So he'll be presenting on adjacent segment disease. Yeah, we can see your presentation.
Okay, sir. So am I audible?
Yes, you're audible. Go ahead.
Okay, sir. Good evening, respected faculty and all the delegates present. I would like to thank the committee of Bombay Orthopaedic Society for giving me this prestigious opportunity for today's talk. I'll be talking about evaluation of the adjacent segment disease of the spine. I'm Dr. Maitreya Patil, and I'm a fellow in spine surgery at the Spine Clinic, Mumbai. So coming to the introduction, spinal fusion was first described by Albay for the treatment of Pott's disease, who performed spinal fusion for the deformity. And almost 50 years ago, cervical spinal fusion was described by Bailey, Badgley, Robinson, and Smith. So accordingly, right now, along the few recent years, because of increase in the fusion surgery, there has been growth in adjacent segment disease of the spine. Adjacent segment degeneration relates to the radiographic changes, which I've described with the help of a paper over here, which are disc degeneration, listhesis, herniated disc stenosis, facetal hypertrophy, scoliosis, and compression fractures. For adjacent segment degeneration, the radiographic guide is present here, which I just mentioned. Lawrence also suggested a term where the adjacent segment pathology can be considered, which includes both clinical as well as radiological adjacent segment pathology. Coming to the methodology of my presentation, I've done a thorough review of the literature from different journals, including PubMed, Asian Spine Journal, Journal of Orthopedic Surgery and Research, and Journal of Korean Library, also Cochrane Library. I'll be presenting my presentation in the following order with description, starting with the anatomy. So basically an overview of the anatomy of the facet and intervertebral disc. It basically forms a tripod between facets and intervertebral disc. The facets may later degenerate due to constant motion of the cartilage. The following risk factors were stated out by the conduction of Department of Spine Surgery in China. These risk factors are as follows. So older the age group, higher the body mass index, and any history of smoking or hypertension can lead to earlier degeneration of adjacent segments. Any preoperative evaluation of adjacent disc degeneration, long segment fusions, preoperative superior facet violations, a high lumbosacral joint angle, any pre-existing degeneration, and pre-op and post-op serratal vertical axis can also lead to ASD. Then after that, we come to the main causes of ASD. We start with the anatomy disruption of the adjacent prior to the surgical level. This is due to mostly a soft tissue disruption to the adjacent level of the surgery. And after that, we come to interdiscal pressure to the adjacent the surgical level. Later on, sagittal alignment and posture. So a study has notably given us that a large pelvic incidence angle and a smaller lumbar lordotic angle are associated with a greater risk of adjacent segment disease. Finally, we also have increased stress on the adjacent segments, any altered biomechanics for the spine, the hardware failure, such as screws, rods, or plates, they may fail and cause irritation to the adjacent segment. Biological factors, some which come into play, such as obesity, smoking, poor nutrition, and finally, aging processes. A few clinical features which I can mention are pain, radiation of the pain, joint stiffness, any numbness and tingling sensation, muscular weakness, changes in gait, loss of bowel and or bladder in severe cases, increased pain with activity, and decreased quality of life. Coming to the diagnosis for the adjacent segment disease, we basically consider clinical evaluation where we take the detailed medical history, followed with a physical examination, which includes to assess the range of the motion, muscles, and reflexes, or any signs of nerve compression. After that, we come to the symptom assessment, where a questionnaire about the pain symptoms or numbness can be done, followed by the location of the location, severity, and duration of the factors that aggravate or worsen the pain. Coming to imaging studies, I've described a few X-rays and MRI and CT scan over here. So over here, we can see an X-ray of the lumbosacral spine in the lateral view, where an L3, L4 single level TLIF has been done, and the segment between L4, L5 and L5, S1 has undergone into adjacent segment disease. Coming to the treatment part, the treatment basically starts always with conservative management, which involves physical therapy to improve strength, flexibility, and posture, which may help and reduce the pain and improve spinal stability. Medications can be NSAIDs or any muscle relaxants. Epidural steroid injections, which cause temporary relief by reducing inflammation and pain in the affected area. Lifestyle modifications include weight reduction, smoking cessation, and activity modification. Coming to the pain management, it's still very controversial. It can include chiropractic care or TENS. And finally, a few biological injections such as platelet-rich plasma or stem cells, and rehabilitation program such as core and back strengthening exercises. Other modalities of treatment may include minimally invasive procedures and revision surgeries such as removal or replacement of hardware, extension of fusion to include the adjacent segment or segments, any decompression of nerve root, and artificial disc replacement. Here we can see an L3, L4, and L5 level fusion done, but the L2, L3 segment has developed adjacent segment, which was later on fixed by placement of a cage. Complications involve as chronic pain, decreased or reduced mobility leading to difficulty in bending, twisting, or lifting, any neurological deficits because of nerve compression, reduced quality of life due to dependency of pain medications, any revision surgery complications, which can be infection, bleeding, or hardware failure. A few recent advances which we can come across are a few biomarkers seen in the CSF, platelet-rich plasma to promote tissue regeneration and healing, improved techniques for 3D and dynamic imaging, and finally, advanced implant materials can be total disc replacement for lumbar and cervical spine, cage made up of titanium alloy or carbon fiber or PEEK, and prosthetic nucleus replacement, dynamic stabilization, interspinous devices, and facet replacement. To conclude, a recap of a few points can be done. ASD can occur after spinal surgery adjacent to the surgical site. Maintaining posterior tension band is necessary. Risk of ASD can be reduced by medical dissection of the tissue during the surgery. Pre-op findings of ASD can be looked after before the fusion of segments. A normal spinopelvic balance is also necessary. Coming to a short case discussion, we have an MRI which shows 49-year-old male with L5-S1 lumbar disc herniation and degeneration of L4-L5 intervertebral disc. You can see in the A and B images. After that, the C and D images show that the patient has gone a single level TLF of L5-S1, followed by he developed an adjacent segment disease in L4-L5, which had to be revised later on. A study that shows that non-instrumented lumbar fusions had incidence of ASD up to 5.6%, whereas instrumented lumbar fusions had 18.5%. Comparison between of ASD between MIS TLIF and open TLIF did not significantly differ. And ASD after PLIF with 10 years follow-up in 101 patients showed that 3 operations were in total of 10 patients, 80% of which were performed within post-op years. These are my references. Thank you.
Thank you, Dr. Maitreya. You finished in 7 minutes, 30 seconds. So now let's open to the judges. Ingalalika, sir, please go ahead with the question.
Maitreya, can you tell me how long does it take for adjacent segment to become diagnosably symptomatic after the surgery, index surgery?
Yes.
How much time should it take normally?
So generally, this patient starts developing symptoms from the period of 3 to 5 years, and they can aggravate after that, sir.
What if it starts in 6 months or 1 year?
So that could be the case, sir.
No, what does that mean?
So a thorough preventive ASD evaluation was not done preoperatively.
What is the thorough preventive evaluation?
So we should check for the dynamic segments, sir, where the mobile segments of spine exist. If in case a patient is undergoing a long segment fusion or a segment fixation, so the segment should be extended one level above the mobile segments. That is, for example, from L1 to S1, then we can extend it to D11 to S1, sir. And also the spinopelvic parameter should need to be considered.
That you told us.
Yes,
you have told us.
Yes.
So and so thing is to be done. But
Yes.
after having patient having developed that, you showed one case where 3-4 fusion was done.
Yes, sir. Yes.
And 4-5 underwent ASD, and
Yes.
5S1 also went ASD.
Yes.
Now, can you really call 5S1 as ASD? Or it was a plain simple process of progressive degeneration, which probably existed? You also showed another case where
Yes.
after L5S1 fusion, 4-5 showed herniated downgoing disc.
Yes.
There are a lot of modic changes pre-operatively.
Yes.
Are these to be truly termed as ASDs?
No, sir. I would term them as degenerative changes.
They were degenerative, which is already existing.
Right.
And you also said that not disturbing the soft tissues of adjacent segment. What does that mean?
So basically, reevaluate and check on the MRI to see if, in case the disc is already degenerated, then we can plan for a instrumentation or a left out, leave alone, and keep the dissection as minimal as possible. Avoid any superior facet violation or anything like that.
What is the commonest way of violating facet?
Sir, in case of a posterior lumbar interbody fusion, so in case during laminectomy or decompression, if the extension is more lateral towards the facets, and so that time the facet can get violated, or even during instrumentation, sir.
What about facet capsule? You'll most commonly remove the facet capsules.
Yes, yes, we shouldn't.
Also, if your point of entry is too medial,
Yes, sir.
then again you can damage facet. If you're
Yes.
sufficiently lateral, right at the base of transverse process,
Yes, sir.
probably those will be spared.
Yes.
You also know that very often in a spondylolisthesis, the pain is not arising from that segment.
Segment.
Very often it's arising from the upper facet,
Outside. Yes.
which is the primary source of pain.
Right, sir.
Therefore, preoperatively, I think giving differential blocks at various levels at different sittings
Right, sir.
and evaluating, noting it down, and then finally doing the surgery, fixation, whatever segments, is a better way of doing.
Right, sir. I agree.
Right, sir. Dr. Satyan, your questions?
Yeah, thanks. So Ashish, good presentation. I'll just ask you a couple of short questions about what is the role for dynamic stabilization in preventing ASD?
So in dynamic stabilization, we use motion segment rods, sir, with allow motion of the segment when the patient is bending or going back, sir. It has the connecting rod and the pedicle screw has motion segments going on in it.
So does it
What is
help
the
to prevent ASD? Is there any
Yes, sir.
study to show?
Yes, sir. Yes, sir. It does help to prevent ASD, sir.
Is that
Are
confirmed
there
or it's a
studies?
speculation?
So it's a speculation which is still under review, sir.
Okay, okay, not sure about it.
Yes.
ठीक है, ठीक है.
Do you have any
That's all.
idea how long does an implant of a flexible implant last in a youngster like you?
No, sir. I don't know, sir.
That's all. Thank you.
Okay, Dr. Neeraj, your questions? Unmute yourself.
There is your
What sir has asked is to the point. Even
Yes.
if the adjacent segment degeneration risk is slightly less with these motion preserving devices, the reoperation rate is much higher.
Right, sir.
Okay, hence the longevity for such dynamic implants is an issue.
Issue.
Okay, so
Right.
so my question to you, what steps you can do intra-op in terms of implant choice, especially at the junctions, with case size or with respect to the tissue. So which tissue we have to preserve on
Yes, sir.
table
So the
to
posterior,
prevent adjacent segment degenerations.
right, sir. So the posterior tension band we should preserve, sir, to
Okay,
reduce the
and
adjacent segment disease. And sir, also as minimal muscle dissection as possible, to limit
Okay.
it towards the segment. Sir, and the interspinous ligaments and should be preserved, sir.
okay. Facet capsule also you have not. Okay.
Facet capsule.
Then regarding the case size, what case size is recommended to prevent which sizes leads to increased risk
So the
of
cage. So the I think the cage above more than 12 mm in length, sir, should be.
okay, and any particular implant at the junctions which will reduce the risk.
So in long segment fixation, we should cover the mobile segments of the spine, and implant to be used should be a dual thread screws, especially.
Okay, I'm talking about the end. Anything used
So,
at
yes.
the end.
So you can use a disc arthroplasty. So you can use a disc replacement for motion segment.
how many with this arthroplasty have you seen or heard having been done in Bombay alone?
No, sir. No.
Have you seen, have you heard a lot of people doing that?
No, sir.
Suppose you are doing a posterior degenerative lumbar spine, lumbar degenerative scoliosis.
Yes, sir.
So what is the preferred choice of implant to reduce the rigidity
Yes,
at the junction?
So I'll do a posterior, a T-lift, sir, and use a cage and pedicle screws and connecting rods, sir. For that, sir, I should prefer a dual thread screw, sir.
How does dual thread work?
So dual thread has a better hold for in cases of osteoporotic bone. So in case the during reduction the vertebra is trying to, so in case the osteoporotic vertebra, the screw won't get a pull out or back out. It will have a better hold, and so we can also use reduction screws, sir, for region screw.
Okay. This is you're talking the concern about displacement from there. Your paper is on the ASD.
Yes.
Right, sir. Right, sir.
He's talking something else.
Maitreya, one simple question that you
Yes.
describe a lot of factors for the preoperative assessment. Now, all these factors has any importance in selection of the implant, or when it comes to selection of implant, it's basically your own concept. They play a very important role.
So I would go for better implants, sir, and so use better
The
bone
question is
grafts, sir.
about the question is about like the factors which you suggested, the preoperative assessment factors. Do they play any role in selection of the implant?
Yes, sir. Yes, sir. They do.
Okay, can you give me the example? Like if these factors are present, then you will go for this implant, and if these factors are present, then you will go for the motion preserving implant.
Yes, sir. So in case of a improper spinopelvic imbalance, I would like to go for a motion segment implant. Right, sir. And so in case of a high sagittal SVA, sir, sagittal vertical axis, I would like to go for a short segment fixation with a cage, sir.
Thank you.
Maitreya,
Yes, sir.
if the spinopelvic balance is disturbed,
Yes.
would you not try to do correction at the level of the PLIF or TLIF that you're doing, interbody level?
Yes, sir. Yes, sir. I would.
So that is what Dr. Thiren probably is asking you.
Sorry, sir. Yes.
Okay, okay.
Okay, I think time is
Say
up,
you-
and
Yeah.
Okay.
we have three
Your
more candidates to
thought
go.
has to, okay, please go on.
So I'd like to invite now Dr. Priyambada Kumar for presenting her talk. Please share your screen. Okay, we can see your screen.
Am I audible, sir?
Yes, you are audible.
Yes, yes.
Go ahead, your screen is visible and you are audible.
Good evening, respected teachers, judges, and dear colleagues. I'm Dr. Priyambada Kumar, working as a spine surgery fellow at Bombay Hospital, Mumbai. It is universal knowledge that early identification of spinal tuberculosis is the first step to combat this menace. And yet, in spite of this, the average time from presentation to diagnosis is a shocking 7 months. This is primarily due to the ill-structured diagnostic strategies being used, especially at the grassroots levels at the PHCs. Exponential increase in immunodeficient states, emergence of atypical TB infection, and rampant rise in MDR and XDR TB strains wreck the spine by the time a delayed diagnosis is made and treatment is planned. Our aim today is to explore the research around early diagnosis of spinal TB and the effectiveness of each investigative modality. PubMed, Google Scholar, and Medline databases were searched for articles published between 2013 to 2023, and the following search terms were utilized. A total of 15 articles were included in our review today. The first step to early diagnosis is to have a high grade of clinical suspicion because the patient usually presents to us with notoriously non-specific symptoms. A person less than 20 years or more than 50 years of age, residing in an endemic region for tuberculosis, coming to us with inconspicuous non-mechanical back pain lasting for more than 4 weeks, with or without paraspinal spasm, should alert the clinician that he might be dealing with a case of spinal TB. Baseline tests such as ESR, CRP, HIV, CBC, and alkaline phosphatase should be done, not because they are diagnostic of spinal TB, but because they effectively help in clinical reasoning. ESR can also be used as a sensitive marker to monitor the therapeutic response over time. Interferon gamma release assay, or IGRA as we know it, is available in two forms, TB Gold and T-Spot, both of which measure the host immune response against 3 TB antigens. However, according to WHO guidelines, these tests are not recommended in TB endemic regions. MRI, especially contrast-enhanced MRI, remains the gold standard imaging modality because it allows best visualization of neural compression and soft tissue spread. Whole spine screening films easily identify skip lesions and allow early institution of treatment and preclude progression to deformity. It is also prudent to do an MRI before stopping the AKT at the end of the regimen. However, if not correlated well clinically, MRIs can give a high false positive results as they are overly sensitive. CT, although highly sensitive to vertebral body changes, is not a specific investigative tool. And so in spinal TB, its role is mostly limited to guide percutaneous biopsies for tissue diagnosis. Nuclear imaging using PET scan allows real-time assessment of disease activity. However, this is expensive and cannot differentiate between malignancy and infection, which is why it is not very frequently used for diagnosis of spinal TB. However, it can be used after initiation of AKT for interim assessment of treatment response. Conventional radiography, according to us, have no role in early diagnosis because of the low sensitivity and also because of the fact that changes are visible on X-ray only after at least 30% of bone mineral loss has already occurred. One needs to understand that none of the imaging options discussed here are reliable in distinguishing spinal infections and neoplasm, which is why tissue diagnosis is a must. Biopsy remains the gold standard investigation of choice, where the sample should be sent for staining, culture, genetic testing, as well as histopathology. Biopsy can be open or percutaneous under CT or USG guidance. It is recommended that at least 2 trials of percutaneous biopsy should be tried before proceeding on to an open biopsy. For microbiological testing, staining can be done using ZN stain or auramine stains. Both these tests are very specific but have a lower sensitivity rate, which especially becomes a problem in spinal TB, which is a paucibacillary scenario. Bactec MGIT remains the gold standard culture modality. It is a radiometric culture assay where the readings are taken at 0, 3, and 6 weeks post-incubation. And if positive, it can give drug susceptibility to all 14 AKT drugs. It has a 100% specificity rate, but the drawback is that it has a lower sensitivity around 56%. And this is where gene expert and line probe assay kind of tests come into the picture. Both these tests work on the principle of DNA amplification and can provide speedy results, have a higher sensitivity as well as specificity. Gene expert can detect rifampicin resistance within 90 minutes, and LPA can give a diagnosis of MDR as well as XDR TB within 48 hours. However, the drawback with both these tests are that they cannot differentiate between live and dead bacilli. TB Quick is another newer modality, not very widely available in India as of now. It is highly sensitive, even more so than Gene Expert, because it detects shorter palindromic repeats for the genomic detection of tuberculous bacilli. Histopathology is a must in all cases of tissue diagnosis. The sample should be sent for histopathology because it helps differentiate between TB granulomas against non-tuberculous granulomas and malignancy. The classical features seen are caseous necrosis, epithelioid cell granuloma, and Langerhans giant cells. This is a renowned paper by Rajshekhar and Sir in Global Spine Journal. Again, as we see that the sensitivity and specificity for all the staining, culture, and histopathology techniques are much higher as compared to generalized tests such as blood tests and MRI, including the IGRA and the Mantoux testing. To summarize the plethora of investigations, a rough algorithm like this can be followed in a clinical setup, where in case of high clinical suspicion of spinal TB, X-ray of the affected part should be done. Although the X-ray is abnormal, if the clinician does suspect spinal TB very highly, generalized blood tests along with a dedicated MRI and a whole spine screening should be done. If there is an emergency indication for surgery, proceed with it, procure the samples for open biopsy and send it for tissue diagnosis. If not, we can stick to percutaneous CT biopsies Again, get the sample for tissue diagnosis and send it for all the testings, including staining, MGIT, gene expert, and histopathology. AKT should be started after a definitive diagnosis. To conclude, diagnosis of spinal TB is a conglomeration between clinical correlation, positive imaging on MRI, and tissue diagnosis. Tissue diagnosis, again, is a multimodal approach. One cannot choose one test over the other. All the samples should be sent for ZN staining, MGIT, gene expert, as well as histopathology. These are my references for the study today. Thank you.
So thank you, Dr. Kumar, and you finished with 50 seconds left in the clock. So over to judges for questions. Ingalarika, sir.
Miss, you said CT scan has very little role in the management. Can you explain a little more about that?
Sir, I did not mean in the management. What I was trying to emphasize is that during the early diagnostic stages, the CT is not used very frequently. It is very sensitive in detecting the radiological changes, the vertebral status, the disc space changes, but it is not specific to TB as such. So which is why an MRI would be a better choice of imaging modality in the earlier stage than CT. CT can be used in the later stages or when we are planning a surgical treatment to judge the level of bony destruction that has occurred. But during the early stages where we want a clue towards a tuberculosis infection, CT has little role as compared to MRI in that scenario.
When you're saying this, are you presuming that lots of your patients will come to you in reasonably quick time or early time? So you're focusing only on the early diagnosis?
Sir, no. So the research that I had conducted today was more towards focusing on an early diagnosis. So we can prevent a scenario where patient is coming to us much later, being referred through various general practitioners, taking different kind of empirical treatment, and then coming to us after considerable bony damage has already occurred. So my try today was to narrow down investigations which could detect the infection at an earlier stage. So.
You said if the patient doesn't have an emergency reason for surgery. Can you spell out what are those emergency reasons?
So if a patient is coming to me with gross neurological deficit or which is of acute onset or a sudden worsening.
Which is a well-established indication. Anything?
Sudden worsening of neurological deficit, sir. Or in case of a cervical tuberculosis, if there is excessive retropharyngeal collection, which is why the patient is coming with dysphagia or breathing difficulty, that can be an emergency situation.
Well, these are well-known, well-established indications. What else?
Excruciating mechanical back pain, sir, because once we do the radiological investigations, if we see there are signs of instability, that could be a condition where we would prefer to proceed with surgery to provide some comfort for the patient because of mechanical stabilization and go for an open biopsy rather than waiting it out.
Would MRI show you that? It's a grossly mechanically unstable, etc. Or CT scan would show that?
CT scan would show that better.
Okay.
CT scan is equally important. Please stay on that. Okay.
Thank you, Ingaraj, sir. Dr. Satyan, are you around?
Yeah. So I had a question, very good, well presented, Dr. Priyambada. My question was that you had a very interesting line where you said that we start AKT only after you get a definitive diagnosis for the patient and not before. Now, very often we get cases where even the histopathology, gene expert, biopsies, etc., will not give us any positive response, and I'm sure you also come across that. In that case, what is your recommendation?
So there are always situations where there is an exception. In case there is a situation where all the tests have failed, Simultaneously, when we are sending for staining, we also send it for other pyogenic anaerobic cultures, staining. If everything has failed, and clinically as well as radiologically, we have very strong suspicion of tuberculosis, then in such a case, we will have to proceed with an empirical treatment and then judge on the basis of how the patient is faring symptomatically if our approach was right or not. But apart from such exceptions, sir, I would suggest it's always better for the definitive diagnosis and then proceed to start the AKT.
Thank you. I learned something new in your presentation about gene quick, TB quick, I think. Can you tell me a little bit more about it, TB quick?
So TB quick also works on the principle of DNA amplification, sir. But the advantage as compared to gene expert is that the code, the genomic palindromic repeat that it is detecting is much shorter. So it's much more sensitive to detect the bacterial genome in the sample. So it has a higher sensitivity rate as compared to gene experts.
And all these tests are available in Bombay, India.
Dr. Dhiraj,
Thank you.
questions?
Yeah. So
Dhiren,
what
sir,
do
you
you
want-
mean by definitive diagnosis, and what's the routine? So he asked about some exceptional scenarios. So tell me your routine when you decide when to start the AKT.
So routinely what we practice is that when the patient comes to us, we have a clinical suspicion of tuberculosis. We are conducting the radiological investigations which are matching the symptoms and our suspicion. Again, if the patient needs immediate surgery, if the surgery would provide more relief than waiting it out, then we go for an open biopsy. Else, we wait for the percutaneous CT-guided biopsy report, sir. And by definitive diagnosis, I mean the battery of tests that I listed, at least one of them giving me a positive result.
Like what?
So like gene expert result, it usually
Okay.
comes.
So if gene expert is spotted, you start the patient on AKT?
Ideally, we do, sir, but there again, we closely follow the MGIT report because gene expert does not give me the complete drug susceptibility. Although I'm starting the patient on AKT at that point of time, I keep a very thorough watch on the MGIT report because at the end of 6 weeks, I need that list of drug susceptibility to all 14 drugs. And then again, I also keep a watch on the patient's clinical symptoms. If the pain is gone, generalized well-being is there, that means my empirical treatment is working well so far. Else, something is wrong. It's resistant to one of the drugs. And that is when I will chase the drug susceptibility report, change the drug regimen if need be after that.
So when you take that call, we have to change the second line. When you don't get anything on MGIT, when you take that call?
I'm sorry, but I haven't faced a scenario where the patient is not doing well.
So many times we get a gene expert positive, and we are not able to grow anything.
So again, that is a scenario, sir, because like I said, gene expert cannot differentiate between a live and dead bacilli, a latent and an active infection. So gene expert will be positive even if the patient has a latent infection or had a past history of infection. Again, the past infection could have caused it. Suppose a patient is coming.
You are not understanding my question, I think. See, again, I will repeat. I think you know the answer. That's what I'm repeating for you. If in a case when we have got a gene expert positive, so that suggests it is tuberculosis. But then we are not getting culture report. So what time you will decide to change the drug modality or to add some more drugs or to change the line of therapy?
But my patient is faring well.
Irrespective, whatever tell me the scenarios now. So what scenario will make you consider that?
The only scenario, the first and foremost that I will look for is if the patient is doing well or not. If he is faring well clinically, it means the treatment is working. So I will not bother changing my regime.
Okay, fine, take it. Okay.
Priyambada, I'm going to ask you a very oblique question. And I want you to answer it scientifically. Would you give generic drugs or would you give branded drugs?
Stop the recording.
Okay, forget about it. Okay. All right. Let's proceed.
Kiran sir, you have a question. Go ahead.
Yeah, Priyambada, like the question is very practical question. In the past, we used to get a lot of, not lot of, but some patients where we have no hard evidence for tuberculosis. But on a clinical ground, we used to start treatment, the anti-tuberculosis treatment. Now, as far as I understand that now government is very strict, and on empirical basis, government does not allow us to start anti-tuberculosis treatment. So have you come across such situation where you feel that, yes, this could be tuberculosis, but you don't have any hard evidence to start the treatment?
Yes, sir. It has happened with us a few times where, again, the patient has come from has been referred from outside, is carrying along with the symptoms, along with the radiological evidence, he's also carrying a positive TB gold test. That is a spot test that is being done in a lot of institutes. But still, TB gold is not considered scientific documentation valid by the Indian government. And so we had to wait for one of these tests to come positive before we could institute the drug therapy under our care.
Would you like to recommend to the government something for such patients where you don't have an evidence, but still you feel that you want to start treatment?
Sir, to be honest, I think it is wiser to wait for a definitive diagnosis because the problem of MDR and XDR TB strains is actually becoming very worrisome. And so I think it would be better to wait for a few days, manage the patient with the pain, with the bracing, and wait for the result to come.
Thank you.
Thank you.
Okay, thank you. Thanks a lot.
So let's invite our next contestant, Dr. Ashish Naik. Ashish, go ahead and share your presentation.
Is my screen visible, sir?
It's still coming on. Yes, now it is visible.
I'll start, sir.
Yeah, go ahead. Your audio is good. Go ahead.
Good evening to one and all present here. Myself, Dr. Ashish Naik. I'll be speaking on vertebroplasty and kyphoplasty, a review of all minimally invasive treatments. So osteoporosis is basically a low bone mass and microarchitectural deterioration of the bone, which results in an increased risk of fractures. WHO defines it as BMD less than 2.5 standard deviations or more below the mean of young healthy adults. As life expectancy increases, osteoporosis increases concomitantly, and spine is the most common side. So 9 million cases occur worldwide, and it's an important cause of morbidity. As the populations are going to age, the number of such fractures are expected to rise even further, and optimal treatment is a challenge. Osteoporotic vertebral fractures cause pronounced pain, persistent reduction of the quality of life, affect physical function as well as mental health, causing morbidity and mortality, which is related to the severity of spinal deformity. Now, Sugita et al. Had given a classification as per which the swelled frontal type, the bow shape, and the projective type had poor prognosis. The natural history says that 70% heal by conservative line of management and 30% undergo pseudoarthrosis, resulting in immobility and neurological deficit. Now, conservative treatment gives good outcomes in about 70 to 80% of the patients. But when are these procedures needed? So patients who are having severe acute back pain, inadequate pain relief despite an adequate conservative trial, who have comorbidities to prevent them from having a prolonged bed rest or analgesics. In such patients, such treatments are needed. Now, minimally invasive interventions allow for height reconstruction. They also allow for stabilization, relief of pain, mobilization, and functional rehabilitation. Methodology was as follows. PubMed, Cochrane Library, and MDs were searched for relevant studies. The following search terms were used, and studies from high impact factor journals over the last 10 years were chosen. Vertebroplasty was first described by Galibet and Dermot. It's an image-guided, minimally invasive procedure which involves injection of bone cement into the partially collapsed vertebra and provides pain relief and stability. The mechanism of action being it increased stiffness, stabilizes the spine, reduces the abnormal micro and macro motions, and also causes chemical neurolysis of the nerve endings. Indications being Dijo type 2 and 3, which has intravertebral instability, acute painful OVF, in which immobilization cannot be done, and Kummel's disease. Contraindications being neurological deficit, asymptomatic fractures, Dijo type 4 and 5, which have intervertebral instability, infective etiology, allergic coagulopathy, vertebra plana, and a severely compromised respiratory function. Kyphoplasty is basically evolution of vertebroplasty, which involves inflating a balloon inside the vertebral body to restore the vertebral height, reduce the kyphotic deformity, and thus improve the spinal biomechanics. The balloon is first inflated, then it's deflated and removed, and cement is injected into the void to maintain the structural integrity. The injection of low pressure cement reduces the risk of cement leakage. Indications and contraindications are similar. One important difference being it cannot be done for acute, it can only be performed for acute fractures up to 7 to 10 days and up to a maximum of 4 to 6 weeks. In older fractures, it's difficult to achieve adequate vertebral height restoration and kyphosis correction. Approach about D9, it's a transcostovertebral approach, and in thoracolumbar and lumbar, it's a transpedicular approach. Pressure means 150 psi for fresh fractures, a maximum to 300 psi. Can be done by unilateral or bilateral porters. Benefits for unilateral means shorter operative times, lesser radiation exposure, and lower complication rates. No significant differences between VAS and ODI scores, improvement of kyphosis angle, and correction of spinal deformity. Now, vertebral cortical defects will result in cement leakages, and which thus, in such cases, the procedure should be terminated to avoid complications. Herein, the egg-shelling comes into place, which prevents the massive cement leakages through these cortical defects. Precisely defects are located, balloon will be deflated and removed. Cannula strategically positioned near this defect, little cement is injected to cover the defect bilaterally. The kyphoplasty balloons will be then reinserted and slowly reinflated to press the cement against the defect, and then we can go ahead with the vertebroplasty or kyphoplasty. The drawbacks of kyphoplasty are it causes displacement and damage to the tremiculae with the balloon inflation. The loss of restored height can take place when balloon has been deflated and cement has been filled, and there is a risk of cement leakage. Now, radiofrequency kyphoplasty has a unique hydraulic pressure delivery system. It has an articulating osteotome which creates channels within the vertebral body and simultaneously creates and filling of cavities possible. Now, in terms of outcomes, it stabilizes fractures and restores the vertebral body height. Lordoplasty depends on the principle of ligamentotaxis. It's basically vertebroplasty performed at adjacent vertebrae. Cement cannulas are in situ. We are used to apply the lordotic moment. Facets act as a fulcrum, and after maximum possible reduction, the fractured vertebra is augmented. Outcomes are comparable to vertebroplasty and kyphoplasty. Vestibuloplasty is an alternative in which a balloon container is inserted, and on inflation, it creates a cavity, and the bone cement is injected into this contained cavity, which limits the risk of leakage and maintains the reduction of fracture and provides stability. Now, it has similar pain relief and vertebral compression recovery, but it has lower spinal leakage, cement leakage. Spine jack is basically a device which is inserted by transpedicular approach. Now, the deployment results in fracture reduction and kyphosis restoration. There is no damage to surrounding trabeculae. The fracture has to be mobile. Injection of the bone cement helps to secure a long-term reduction. Main advantage is end-plate restoration, which decreases the incidence of progressive collapse. Key-wise, another special delivery tool, which positions an initol guide wire. The implant is inserted and the guide wire is withdrawn and bone cement is injected into the implant. It is superior to vertebroplasty and kyphoplasty, has decreased incidence of cement leakage and maintains the kyphosis angle. Cement and alternatives. Most commonly, a PMA-based cement is used. Wide varieties are available based on the surviving agent, viscosity, the working time, and exothermic reaction. Other new types are coming up. Complications can be intraoperative or post-operative. Now, what is the latest data? So across here, evidence has shown the patients who are subjected to a more rigorous selection and those with severe pain treated less than 6 weeks from fracture onset are good candidates for vertebroplasty and kyphoplasty, and this has been validated multiple RCTs. In terms of outcomes, pain relief in acute OVF is 90%, chronic being 80 to 100%. Mobility in acute is 84 to 93%, chronic being 50 to 88%, and reduced requirement of analgesic 91%. Two trials by Binder et al. And Kalmus et al. Said that these are basically sham procedures and they are not superior to placebo. But it was found that they basically included chronic fractures and pre-procedure MRI was not done. Now, the Vapor trial and Vertos trial, which are basically multi-center double-blind RCTs, proved that these procedures are superior to placebo and pain reduction in these patients does occur. In terms of vertebroplasty and kyphoplasty, on comparison, this meta-analysis shows us that clinically there are no differences between the two. Radiographically, kyphoplasty is better. In terms of complication, cement leakage is lower in terms of kyphoplasty, but other complications are almost the similar. In terms of intraoperative resource consumption, vertebroplasty has smaller amount of volume injected, a shorter operative time, fewer fluoroscopy times, lower operation cost, and the volume of blood loss is also smaller. Thus, to summarize, Osteoporotic fractures have a benign natural history. The primary indication has to be a painful OVF, which is refracted to adequate non-operative treatment, or acute fractures who have severe pain and blood loss is not advisable. Absolute contraindications with infection, intervertebral instability, and uncontrolled coagulopathy. Major complications are uncommon, but cement embolism and cement leakage can occur. It has a success rate of about 95%. Thus, proper patient selection is vital. The first step is to confirm that the collapsed vertebra is the source of the pain. Next step is to exclude the other causes, and finally to rule out the intervertebral instability, which may require instrumented stabilization. Future research can be on artificial intelligence and augmented reality, bioactive PMA biomaterials for augmentation, customized bioabsorbable and bone-forming materials. These are my references. Thank you.
Thank you, Dr. Ashish. And you took around 30 seconds more to finish.
Okay,
So
sir.
let's invite the judges for questions. Ingalalikar sir, over to you, sir.
Yes.
Good evening, sir.
Can you tell me which of these various methods that you described, they are
Yes, sir.
truly biologically healing methods? Biologically healing, as against buttressing or supporting methods.
It will depend upon the cement injected, sir.
See, is the cement a biologically active?
No, so
Structures?
biologically active cements are coming up, but as of now, we are currently using the PMA-based cements, which are most shortly buttressing the defect and filling the defect, and not biologically active. They are not healing the fractures biologically, but basically just causing the height restoration and biomechanically improving. As of now, we are not using any cements which will heal the fractures biologically.
So the bone of that particular body, upper part and lower part,
Yes,
with
sir.
a blob of cement in between. Where's
Yes,
the
sir.
biological bond? It's only buttressing?
Yeah, it's
Mechanically?
buttressing mechanically, sir, but because the height has been restored, so that would help the patient in terms of pain relief and help in mobilization, which would be our ultimate goal in such fracture.
Is that the reason for pain relief? Many patients whose fracture collapses and heals. So the angle is not changed, like you say, and
Yes,
the
sir.
patients have zero pain. So do you think this angle is what gives the pain?
No, sir, the
And
angle is
angle gives relief?
No, sir, not the angle, but the natural history is important. So like 70% will be healing on their own by terms of conservative management. The 30%.
That we all know. We all know about it.
Yes,
You're
sir.
talking about this. What is the biological thing? Suppose you follow your vertebroplasty 6 months, 1 year, 2 years. What do you see there?
There will be.
What do you see? What is the long-term benefit or short-term, middle-term benefit of a
Short-term benefit
vertebroplasty?
would be in terms of pain relief.
Of pain.
Sir. Yes.
Completely agree with you. Completely agree.
Long term, sir, basically we are just helping the patient overcome. So these procedures are indicated only when there is intravertebral instability. So we are just helping the patient overcome the symptomatic pain period, after which the body's natural healing response will take over and the patient will recover, sir. So we are actually just buttressing and... Sorry, sir?
Have you seen displaced cements?
I have seen, sir, but not in my institute, sir. Cement leakages I have seen, sir.
Not leakages, displacement of a solidified buttress.
No, sir, I have not seen, sir. I have not seen, sir.
Okay.
No, sir.
Okay, sir. Dr. Satyan, you are around?
Yeah.
Okay.
So, good presentation, Ashish.
Thank you,
I
sir.
wanted to ask you about one point which you said, that where vesselloplasty is superior to vertebroplasty and kyphoplasty. This my first question is on this. Okay, yeah. Okay, can you explain on that?
So my point was that it's better in terms of reducing the amount of cement leakage. So now cement leakage could be symptomatic or asymptomatic, but in terms of cement leakage, it is better. the
Which is
outcomes which have shown that
which
there
is
will
the main indication for doing a procedure, vertebroplasty, kyphoplasty, vestibular, anything? What is the main indication for doing this?
basically, sir, 2-3 fractures who have acute painful fractures and the patient cannot
Acute
be
fractures?
immobilized.
So you were doing it in acute fractures?
Vertebroplasty, sir?
Yes.
Yes, sir. Like if the patient is like initially, if a patient comes to me, I will offer him conservative line of management. But suppose the conservative line of management cannot be done, like it fails after an adequate conservative trial. Also, the patient
What is adequate?
About like 3 to 4 weeks of conservative trial of management in which the pain is the VAS and ODI scores of the patient are having a decreasing trend. The patient is able to mobilize. Like patient should be given a bed rest only for a few amount of days, after which he should be able to mobilize at least with a brace. If he is not able to do that, not able to carry out his activities of daily living, he's been confined to his bed. Most of these fractures will take place in elderly people. So if he's been confined to bed, all those morbidity and mortality
See,
issues.
I'll tell you, I'll go back to you. You have put on indications. You have actually presented in your indications.
Yes,
which was your number one indication for doing this procedure?
a very acute, painful osteoporotic
No.
fracture.
You go back to your presentation. What was your main indication?
The Digit 2 and 3 fractures, sir.
Okay, ठीक है, forget it.
Yes, sir.
Okay.
Dr. Ashish, are you aware of the fact that the
Yes, sir.
incidence of vertebroplasty over last 10 years or 20, 15 years is reducing?
Yes, sir.
Why?
So initially, like when vertebroplasty came, it was being applied and people were seeing good results. But then it came on to be applied to like multiple places, like multiple fractured vertebra. And then the basically patient selection was not been appropriate, and then it led to a lot of complications. Also, it was observed that even with conservative treatment, the patients do improve naturally. So we are just trying to overcome the painful period for the patient.
You said it's contraindicated in infections.
Yes, sir. As per literature.
Have you seen people using cement in presence of some infection?
I have seen, sir. I was talking just in terms of vertebroplasty, sir. I mean, even if there is a spondylolisthesis or surgical site infection, then we do use antibiotic beaded cement. But I have not specifically seen a vertebroplasty or kyphoplasty being used in terms of, say, surgical site infection or spondylolisthesis, sir.
All right. All right.
Okay, Dr. Neeraj, your questions.
So, Ashish,
yes,
so what are your cases where both this vertebroplasty as well as kyphoplasty won't work? And what's the other modalities will be preferred?
So
how you select in an osteoporotic fracture? You won't go for a vertebroplasty as well as kyphoplasty.
So if there is a Digit 4-5 type of fractures, which basically means an intervertebral instability is that the PLC is damaged. In that terms, a short or long segment instrumentation will have to be done along with augmentation. If there is a neurological deficit, then definitely we have to decompress the spine. In that, we will not be able to just use the vertebroplasty or kyphoplasty. If there is an allergy to cement, if there is severely compromised pulmonary function, in all such cases, sir, we will not be able to go ahead with vertebroplasty or kyphoplasty.
So, so how you will augment the vertebra?
Like a short segment or a long segment instrumentation.
Instrumentation?
Yes, sir. Instrumentation.
Apart from that?
So like if osteoporotic fractures, we can use a cortical bone trajectory, which was described by Santorini. We can use longer screws or larger segment fixation. All this can be used to augment if a cement-based procedure cannot be used, sir.
Okay, thank you.
Okay,
yeah. Ashish, like if someone comes to you, some company, and says that we want to improve the cement. So what will be your suggestions for improving the cement? Because some of the complications are related due to cement quality. Yes. So what will be your suggestions?
My suggestion would be, sir, if you could develop a cement which is more biologically active, which is bioresorbable, so that which is osteoinductive and conductive. So once the fracture heals, the basically bone will form and a natural healing will more take place. That would be my suggestion, sir.
Okay, good. And anything about the stiffness? Would you think that reducing the stiffness would help us in reducing the
if
for
we
the
could
future
reduce
complications?
if we could reduce the stiffness, sir, then ASD like could be avoided, sir.
Okay, thank you.
Thank you, sir.
Okay. So thanks, judges, and thanks, Dr. Ashish. We'd like to invite our last contestant today. Is he here already? The last contestant, is he here? Dr. Kushal?
Yes, sir. I'm here. Am I audible, sir?
Yeah. Dr. Kushal, go ahead and share your presentation.
Yeah, sure.
Dr. Ashok, should all the contestants should be present at present or they can leave?
No, they can leave.
So other contestant who have already spoken can leave now.
Hello. Good evening, everyone. Is my screen visible?
Yes, your screen is visible and you're audible. Go ahead.
Okay. Good evening, everyone. My topic for today's presentation is laminectomy versus laminoplasty, a comparative review of techniques and outcomes. These are my disclosures. So let me start with this case example. This 60-year-old male who presented with spastic tetraparesis with motor power of 2 to 3/5 in all 4 limbs with bilateral hand grip weakness with MGO score of 6, barely able to stand and walk. X-ray shows a neutral spine with some lordosis on extension. MRI is showing a significant anterior cord compression from C2 to C6. And coming to CT scan, we can see that there is a mixed type of OPLL, which you can appreciate. Coming to the second case, another similar patient, a 65-year-old male with spastic tetraparesis with all 4 limb power of about 3 to 4/5 and MGO score of 6, barely able to walk with walker support. However, on X-ray, we can see that there is a fairly maintained cervical lordosis. MRI showing multi-level spondylotic changes with significant anterior cord compression. So, these both cases are having similar case presentation, but they have different etiologies with different cervical spine alignment. So what should be the ideal treatment? Whether one should do laminoplasty or laminectomy. So literature is very clear whether one should do an anterior procedure or a posterior procedure. But there is a dilemma regarding what type of posterior procedure. So therefore, we conducted this review to compare the safety and efficacy of laminoplasty versus laminectomy with regards to clinical, radiological, and surgical outcomes, and also to compare and study their surgical complications. So we searched all these databases with PRISMA guidelines followed, and all studies published until September 2023, which compared laminoplasty and laminectomy for degenerative cervical myelopathy, were included in this review. Just an overview of these techniques. So laminoplasty is a technique in which we drill troughs on both the sides and lamina is elevated on one side, which helps in the posterior migration of the cord and decompression. So this is the open door technique. In French door technique, a midline split of the lamina is done. And finally, the fixation is secured with the help of many fragment plates. So laminectomy is a procedure in which we remove en bloc the posterior lamina. It may be supplemented with an instrumented posterior lateral fusion. So coming back to the methodology and selection criteria, all randomized controlled trials or observational studies that compared clinical outcomes between laminoplasty and laminectomy with or without fusion were included in this review. So as per PRISMA guidelines, we recorded 587 records through database searching, and after identification and screening, a total of 15 studies were included in this review. Parameters assessed included surgical, clinical, radiological parameters, and C5 palsy and complications were also recorded, which are enlisted here. So this master chart shows all the studies which we reviewed. Total of 15 studies were reviewed, of which there were 3 RCTs, and these were the parameters which I recorded. The mean follow-up ranged from 8.8 to 72 months. So coming to the results, the post-operative JOA score and VAS scores and surgical outcomes were comparable in both the groups. However, we found that post-operative cervical curvature index and neck disability index laminoplasty showed better results. So C5 palsy rates were higher in laminectomy group. Superficial infection rate occurred significantly less in laminoplasty group. Other complications were comparable. Overall, laminectomy with or without fusion had higher complications. So coming to the overview of techniques, cervical laminoplasty is used to treat multi-level cervical spondylotic changes, multi-level OPLL. Hirabayashi was the first who described the open door technique. The video demonstrates the open door technique of cervical laminoplasty, in which troughs are created on both the sides and open door lamina is opened, which is fixed with the help of many fragment plates. And advantages are that it maintains a greater degree of motion, and because of maintenance of the protective covering over the spinal canal, there is reduced formation of a post-laminectomy membrane, which over time prevents the late onset neurodeficit which happens. There are three techniques which are described for laminoplasty: open door technique, French door technique, and a T-saw technique. So the ideal candidates for laminoplasty are symptomatic multi-level spinal cord compression with a straight or a lordotic cervical spine with minimal axial plane. Relative contraindications include kyphosis and segmental instability. So most patients require a C3 to C6 laminoplasty. Viterbo et al. Recommended doing a C2 and a C7 dome osteotomy while performing this laminoplasty so that the spinal cord can drift posteriorly without getting kinked at this lamina. Complications include epidural hematoma, infection, post-laminectomy kyphosis, decreased range of motion. Axial neck pain, however, is more common in C3 to C7 cases as more compared to C3 to C6. C5 palsy occurs with the incidence of 15 to 16% in laminoplasty. However, most cases recover within 6 months to 1 year with physiotherapy. Another technical complication which is encountered is a laminar closure, which can occur in around 5% of cases, and non-unionate hinge side, which can occur in 9% cases. Coming to cervical laminectomy, the main advantage is that we can decompress the cord under direct vision, and bilateral foraminectomies with a laminectomy width of more than 15 mm decreases the risk of C5 palsy. When added with instrumented fusion, it also prevents progression of OPLL. Main disadvantages of this technique is that it has increased post-operative axial neck pain with high rate of infection and high C5 palsy rates. When laminectomy is performed alone, there is an increased risk of post-laminectomy instability and kyphosis. For example, in this case, this was a 69-year-old male who underwent laminectomy only. At 2 years follow-up, he presented with C3-4 instability with kyphosis and worsening myelopathy. So these posterior techniques rely on the posterior shift of the cord. Posterior spinal cord drift helps in the indirect decompression of the spine in a lordotic cervical spine. So this case example of a 69-year-old male at 1 year follow-up MRI shows adequate posterior drift with who underwent a C3 to C6 laminectomy and improved clinical results. So in cases with preserved lordosis, laminoplasty is a good option. And in flexible kyphosis, laminectomy with instrumented fusion should be chosen. So these two case examples, they compare laminoplasty with laminectomy. Here we can see that both patients improved clinically and adequate posterior drift of the cord is seen with good MRI results as well. So these recent advances, a recently advised technique of laminoplasty with fusion can be considered in patients with local kyphosis and OPLL with segmental instability. It gives advantages of both these techniques. Limitations of this review were that we only included 3 RCTs. There were 12 observational studies with level 3 evidence. The studies were heterogeneous with respect to patient population, etiologies, different surgical techniques, and different follow-up time. And this was a narrative review, but did not do a meta-analysis. Thus, to conclude, both laminoplasty and laminectomy are effective techniques to improve outcomes in DCM. Laminoplasty had better results as compared to laminectomy in various parameters. Laminectomy with fusion had higher complication rates, including higher rate of C5 palsy. One must always consider preoperative sagittal cervical alignment before considering surgery for degenerative cervical myelopathy. And in OPLL, laminoplasty preserves range of motion and improves neck disability. However, laminectomy and fusion, it suppresses the progression of OPLL. So these are my references, and I would thank you all for your kind attention.
Thank you, Dr. Kushal. You finished 30 seconds before time. Now over to judges. Single Harikar, sir, over to you, sir.
Kushal, you have worked in spine surgery, and I'm sure you must have seen laminectomies. Were you unhappy with them? Kushal, can you hear me?
Kushal, can you hear us?
Your voice is inaudible, sir.
Can you hear me?
Can you
Kushal,
hear?
can you hear me?
Hello. Yes, sir. Now,
Okay.
yes, sir. You're audible now, sir.
You have given us literature review, but you yourself must have seen laminectomies. Or you saw only laminoplasties?
Yes, sir.
What have you seen more?
Yes, sir, I have
Laminoplasties or laminectomies?
Sir, I have seen laminectomies with fusion. Laminectomies rarely I have seen. Very rare. On rare occasions, I have seen just laminectomies. I have seen laminectomies with fusion, instrumented fusion.
With fusion. But you have not seen as many laminoplasties.
I have seen equal number of laminoplasties as well, sir.
Okay. Are you convinced that if after laminoplasty, cervical mobility is good?
Sir, in both the techniques, including laminoplasty also, we find that the range of motion at 1 year follow-up decreases, but around 30% decrease in the range of motion. But when we compare it with laminectomy and fusion, there is significant reduction in range of motion.
You know, once you've done fusion, you've done fusion. You cannot compare fusion with a non-fusion.
Sir, in laminectomy only, plain laminectomy, also there is a reduction in the range of motion. But also with laminoplasty, I have seen that there is reduced motion.
Who says that the reduction in the mobility? In fact, I think the best mobility, if at all you want, is the laminectomy.
Laminectomy, yes, sir.
For the best range of movement. They have near normal movement.
Yes, sir.
How common is C5 palsy?
C5 palsy can occur in about 5 to 15% of cases, sir, of cases undergoing posterior decompression surgeries.
But is that related to undervision, non-vision? If it can happen under open vision, laminectomy, can it not happen under the closed laminoplasty? Non-vision.
Yes, sir, it definitely happens with it because both these procedures, they rely on the posterior drift of the cord. So when the drift happens, the C5 nerve root, which is present at the apex of the lordosis, gets stretched. So this results in the traction palsy of the C5 nerve root. So it can happen with both the procedures, sir.
Well, let me tell you that palsy is not that common. Some people do have C5 pain or some dysesthesia,
yes, sir.
But
yes,
palsy per se is not common in none of the procedures unless the surgeon is a very ruffian.
Right, sir. Let's move on to Dr. Neeraj. Neeraj, go ahead.
Yeah. So you have mentioned a lot of benefits of laminoplasty. Tell me a few drawbacks of laminoplasty against laminectomy.
So a few drawbacks would include that there can be a closure of the laminoplasty, which we have opened and fixed with many plates. Right. So that is one of the drawbacks. Also, during surgery, a technical complication which can happen is fracture at the opening of the hinge. So that fracture fragment can dip against the spinal cord and cause neurodeficit. So that is another important complication which one. Yes.
Good. Okay.
How easy it is to put a screw in the lamina or in the lateral mass during laminoplasty? What is the diameter? What is the thickness of the lamina there?
Sir, we usually put the screws in the spinous process and the lamina. So the spinous process is quite thick and we get a good hold. And the lateral mass, definitely we get good hold in the lateral mass, sir.
You put it in the spinous process.
Yes.
And in the lateral mass.
In the lateral mass and in the intervening part of the lamina where it is thick, where both the lamina are connecting, we put the screws there. So that is almost around 4 to 5 mm thick, sir. We can put around good screws, sir.
You have not seen loosening of those implants?
Sir, we definitely, if initially the hold is good and if the screws are in good position, intraoperatively I have not seen, but postoperatively I have seen the plates coming off and the closure of the laminoplasty which has happened. So sometimes it does happen, sir, in a few cases.
How soon do you mobilize them?
Sir, laminoplasty, we usually give them a soft collar, and after suture removal, within depending upon the patient's pain, we usually mobilize them within 3 to 4 weeks. Up to 2 weeks, sir, we give them a soft collar, and then we start mobilization, sir.
After
Till
2 weeks, you
suture removal is
discard
done.
the soft collar also.
Yes, sir.
So you're heavily depending on the mechanical strength of a plate or a screw against the lamina. Correct?
Sir, not just the plate, because we have preserved the posterior structures. We are not disrupting the posterior.
Those are soft tissue
tension.
structures. They don't give stability. And especially if you're trying to mobilize one segment against the other segment, do you think such a small flimsy thing would hold? I have seen large
Sir,
number of displaced implants and failed laminoplasties.
Sir,
Large number of them.
Yes, that does happen, sir. But the moment which happens, it happens in the sagittal plane. There is so the stretch
What
which
about
is put on the
rotation?
implant is low.
What about rotation?
Rotations also.
One
yes,
of the
it
most
can.
common movement next to flexion, rotation.
Rotations.
I
Sir,
would
but I
wrench
have
out
not.
my screws.
Sir,
Okay.
but we usually follow this
Oh.
protocol, and we have found good results, sir.
So tell me where fusion happens in laminoplasty.
Sir, the fusion happens at the hinge where we have opened the door of the laminoplasty. The fusion happens at the hinge. So if the hinge is
Right.
fused nicely, which takes almost 3 to 6 months, then usually the closure does not happen.
Right, right. So
And
tell me
also
how,
in
so
cases
you
where
told about, yeah, tell me, complete.
So also in cases where recently some people have advised use of spacer where we open the lamina. So if the spacer is used, that is another place where fusion can happen along with the plate.
Okay. So tell me, conceptually, anyway, we are decompressing the posterior elements, removing the posterior elements and opening the canal posteriorly. There is a breach in the posterior ligamentous complex anyway.
Yes, sir.
We are opening the lamina. So suppose from C3 to 6 we have opened up. There is
Yes,
disconnection between C2 and C3 as well as C6
Yes.
and C7. Okay, so posterior ligamentous complex is breached. So how does it prevents what in long term you mentioned reduces the kyphosis part? Anyway, there is a breach in the posterior ligamentous complex. No.
Yes. Sir, to answer this, we have preserved the spinous process and the lamina as contrast to laminectomy where we remove the lamina. So after preservation of this posterior bony structures, the muscle and the ligaments, they attach on this bed of the bony structure of the spinous process and the lamina, which over the period of time get muscle attachment of these structures. So that helps preventing in the long-term complications of neck pain, axial pain, and also helps in reducing the neck disability.
Have you seen post-operative MRIs of such patients?
Yes, sir.
We find a lot of fibrosis there posteriorly, which probably prevents the flexion attitude. Rather
Sir,
than
we
your
do see, but sir, usually we perform the MRI at 1 year to see the, so that does not, in the initial period, we do find some edema, but at 1 year follow-up, sir, we did, the MRI does show some
that time
fibrosis,
you
but
pay
not very much.
attention only to the expansion of the cord. You don't look at other things.
Yes. No, sir, we do, sir. We have all the cuts. We have a parasagittal cut as well and an axial cut as well of the MRI,
Okay.
which shows that the muscle has attached well to the lamina, sir.
Okay. All right.
Last question. So what are the theories which leads to C5 palsy, and can we do something, predict it preoperatively and do something intra-op also to prevent this?
Sir, as I mentioned earlier, that C5 nerve root lies at the apex of the lordosis, and all these posterior techniques rely on the posterior drift of the cord, the posterior fallback of the cord. Also, so when the posterior fallback happens, there is a traction on the C5 root, which causes C5 traction injury. Also, the course of the C5 root is pretty straight, and shorter nerve root is present. So all these factors together predispose C5 nerve root more to getting palsy and C5 radiculopathy. And to address your second question, intraoperatively, in cases where we do laminectomy, we can perform bilateral foraminotomies and prevent that complication. Second technique is when we are doing a laminectomy and fusion, we should not contour the rods which we are placing. So we should fix the rod in the neutral. If the spine is neutral, we should fix the rod in neutral. We should not even extended lordosis to the rod. So this contributes to the palsy. And third, we can use intraoperative methylprednisolone where we are doing decompression. Use of steroids intraoperatively has shown to reasonably reduce the incidence of C5 palsy at the time of decompression if administered.
Dhiren sir, any question?
Yeah, the Kushal, you have done a wonderful literature review. My simple question is, for which indication you suggest laminoplasty and for which indications you suggest laminectomy?
Okay. Sir, as I described earlier, we take into account the cervical lordosis and the cervical alignment based on X-ray and also the type of compression. If there is coming to the alignment, if the alignment of the spine is neutral or if there is a flexible kyphosis, so in extension, we are getting a good lordotic spine. So I would go with laminectomy and fusion. While if the cervical lordosis is well maintained, then definitely a laminoplasty is a good option. Secondly, also the type of compression and the etiology. OPLL seem to be doing better with laminoplasty only. And in cases of multi-level spondylotic myelopathy, both the options are
laminectomy.
Yes, but also, sir, again here there are two schools of thought. For laminoplasty, there are some proponents who suggest that laminoplasty is better, and other proponents who suggest that there in multi-level OPLL, if we are doing motion preservation, it can lead to progression of OPLL. They recommend doing a laminectomy and fusion to prevent the progression of OPLL. So,
what's the level of evidence for that? For laminectomy and fusion and
sir,
prevention
the level of evidence is level 3 studies. Yes, sir. These are only level 3 studies, sir. We don't have a solid evidence to prove this, sir.
Okay. Good.
Great.
Okay. Thank you very much.
So we come to an end to the session, and I think all of them presented really well. Did the literature review quite thoroughly.
Yes.
So congratulations to all of you.
Spine has a bright future, I think.
Yeah. So at the end of the session, every session we invite the
only say
judges.
boys have a bright future. The girl also.
So, I said spine has a bright future. Yeah, it's not boys.
So at the end of every session,
she's already a star, sir. She has won 2 prizes.
All of them have worked hard. All of them presented well. 19-20 hai.
Okay. So like I was saying, at the end of every session, we invite the judges to share some remarks to encourage them who are presented today and who will be presenting in the future also. And regarding this BOS Rising Star concept and the event.
One point I would like to, like Shyam says,
yes, sir.
One point I would like to make here is, you people are youngsters. You don't have your own experience, a lot of your own experience. So you're obviously basing your opinions, your thoughts on the literature. Agreed. But when you try to defend those papers, be careful. Very often you cannot defend them well if you are asked questions. Therefore you say, sir, this is what is said in the literature. This is what literature says. You don't try to authenticate that by supporting or trying to defend it, because then you can be smashed. Therefore, when you review literature, you just speak square. Also, we expect you, people, after having read the literature, having studied all those meta-analysis, etc., to still form your own opinion. Your opinion may be youngster's opinion. It may be slightly inexperienced opinion, but do give your opinion, not calling that as your opinion, but saying, rationally speaking, I feel this is what could be done. And I would love any one of you making that kind of a statement, sir, taking into consideration all these papers, all these experiences through the world. I feel most rational thing to do, or probably rational thing to do, is to do A, B, C, D. I would be happy to hear that kind of a presenting point or presenting direction from you people, because that gives you credibility that you also have thought of your own, which you're putting in. And now onwards, we don't want these presentations like an undergraduate or PG will give. You are consultants. And your presentation has to be consultant's presentation. And when we say that, we want your opinion, well weighted, well thought of, added to that.
Okay. Your comments, Neeraj?
No, the way they all have presented, I'm quite impressed with all of them. Even during that time when I was at their age, I won't able to present so nicely what they have done. So I'm quite impressed with the way everybody has prepared. And yeah, I have nothing to add with this present program. I'm quite happy with this. Only thing we can do next time, we can take their own publications or research work also, and we can discuss on them that if at all, if required. Otherwise, the way this program is, it's good overall. Yeah, and obviously they won't have any experience of their own. They have to rely on the literature.
Hiren, sir?
Yeah, the good point is like all have a wonderful presentation skill. Like they presented their ideas, their views really well. The only suggestion is like some of the slides were really with a small font and they were really difficult to read. So I would suggest that please follow the rule of 5 lines in a slide and not more than 5 words in a line. That is a standard formula, and see, by increasing the number of slides, we don't pay anything in PowerPoint. So it's very important that your text should be visible to the last person, the person who is sitting in the last row should be visible. So that's the only thing. And I wish you all the best for future.
Thank you, sir.
Ashok, I would like to one more point.
Yes, sir, go ahead.
See, we did find that some of the candidates focus their talk only around what they had studied in those series and etc. If you're talking on a point or say vertebroplasty, I'm just giving example. I'm not saying about vertebroplasty. Then when you present this, you must know everything around the vertebroplasty, irrespective of what those papers you are summarizing and presenting. Because if you're going to be asked questions, you should be able to answer everything concerning those areas, not only what has been presented in that. What probably happened with 1 or 2 people is they only stuck to what they have studied in those papers and spoke only around that. Compared to that, some people spoke very largely around those topics, which I liked. That means they were knowledgeable about that. I'm sorry I'm taking the name, but when a Priyambada spoke about TB spine, I got a feeling that she knew everything about what she was talking. While some of you did not give me that feeling. I mean, now that the result has been already sealed, I'm taking her name. Priyambada, don't consider that you have been selected as the first, because I said this. Okay, but I could make out that she knew everything about TB test, everything about that, and she spoke. Now that is something which we expect when you are presenting any paper, any preparations, any meta-analysis, any studies like this. You must sound like a dada in that.
Right, sir.
Yeah.
So in the end, I'd like to invite Dhar sir to say a few words, thank the judges, and invite for viral. Over to you, sir.
Thank you, Ashok. Thank you, judges, for providing your time in the busy evenings and giving credibility to this competition and encouraging these young guys who, with their amazing presentations, that is the whole point of this competition, that we push these young guys to the forefront of this academic, what is the jungle, and so that they have faith in themselves also, and we as seniors sort of reveal them out to the whole world and probably push them 5 years ahead what they would normally take. I'm sure they are talented and they would have anyway come out on the open, but this BOS is trying to provide a little flip to their abilities, so they would present it faster. So you will be I'm sure you will all be inspiration to the now probably, as Dr. Dhiren was also saying, that there are competitions coming all over the country now. It's simply so you are predecessors to all this, and I'm sure you will remember this as in the long run of your career. So thank you very much, everyone, for being there. I'm sure we are building up to an amazing competition in the YROC, and see you there all. And I'm sure we'll have a good time there. Back to Ashok. Thank you, VTI sir, and thank you, Dhiren, and
Welcome.
Dr.
Pleasure to
Dhiren,
be here.
Dr. Neeraj, and Dr. Satyam.
Thank you, sir.
Thank you very much, sir.
We have a viral video to play for all of you. Thanks again, everyone, and we come to end of this program. Thank you very much.
Thank you,
Thank you
sir.
very
Thank
much.
you, sir.
Good
Good night,
night.
sir.
Thank you, sir. Thank you. Good night.